Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I have a very special guest in PEM Rules. He's a special guest because he comes from a field that most of us who graduated medical school, residency, and even fellowship don't have significant knowledge in. And I'm talking about ophthalmology. As a pediatric resident and even as a PEM fellow, and certainly after finishing medical school, I must say my personal experience beyond corneal abrasion and conjunctivitis with any eye problem is quite limited. Sometimes those kids are a very significant challenge. That's why I invited Dr. Mitch Strominger, who is a pediatric ophthalmologist here in Nevada, to come and talk to us about common ophthalmological presentations we see in the pediatric emergency department. Thank you, Mitch, very, very much for coming on the show. I know you're a very, very busy physician with a lot of hats, so I appreciate your time. Let me just introduce you briefly to the PEM Rules listeners. Mitch, and please correct me if I'm wrong at any point, you are originally from New York. You went to college and medical school at Washington University in St. Louis, graduating in 1986. You then, for some reason, completed residency in internal medicine in Rochester, New York, and then went to an ophthalmology residency also after that in Albert Einstein College of Medicine. So you did two residencies, is that right?
Yep, that's right.
Followed by one fellowship in neuro-ophthalmology in the University of Miami, and then another fellowship in pediatric ophthalmology back in New York. Is that right?
I think you got it all there. It's a long haul, but I made it.
So again, just to make just so we're all clear, two residencies, two fellowships.
Yeah.
That's impressive.
Neuro and pediatrics.
Very impressive. And then I know you served as faculty at Tufts University in Boston, and as well as in Mass Eye and Ear Institute in Boston, which I'm very familiar with because I used to live in Boston for a while. So been very, very active, obviously very knowledgeable and experienced physician, which is why I'm super excited to have you on the show. Good morning, and how are you?
I'm doing super. Thank you very much. It's becoming springtime here in Reno, Nevada, but we're supposed to get a little snow this weekend, so you never know, right?
Oh, wow. That's exciting. How often do you guys get snow over there?
Well, it's funny because we get a lot of snow in the winter, but down in the valley, it doesn't last for very long. We got, I don't know, something like 105 inches up in the Lake Tahoe basin, so the skiers were happy. And then during May, sometimes we get these cold fronts move through and everyone's ready for spring. And then all of a sudden it gets cold for a couple of days. We get a little snow, but it doesn't stick.
And I'm sure as a New Englander, that doesn't get you very excited, obviously.
I'll tell you, it's been a pleasure moving out here in Nevada. It is the most perfect weather ever compared to New England, where it would stay 10 degrees for weeks on end.
I've been here in Las Vegas for a while, and I agree. The summers are a little tough, but the weather is really great otherwise. So Mitch, first question to you and to all the guests in the show. Everybody has their own perspective, which is great. What is your definition of a good pediatric emergency medicine provider? One who does what?
Well, I'll tell you, you guys have a very tough job, especially when it has to deal with ophthalmology, because ophthalmology training is pretty minimal in medical schools in the United States now, and even during residencies and especially during fellowships. I mean, I help teach the pediatric residents, and they'll come through my office every couple of days, maybe during their training. But I've never really had an emergency room medicine resident come through. So, I think the first thing is to understand some basics of ophthalmology. I think that's a given. And that could be taught, and hopefully people are motivated to do that. I talk to emergency room medicine physicians all the time, every couple of days, and I'm really impressed by the guys who've sort of kept up with ophthalmology and really understand the eye, and especially the structures of the eye, and sort of the most important diagnosis that they're going to see. And the ones that I tend not to respect as well are the ones who just call and ask me to come in and see a patient without even necessarily examining the individual, which I think is a tough thing. So my recommendation, I really respect those guys who really are interested in the eye, and also the ones that want to learn. If I'm going to spend my time coming into the emergency room and examining a patient, what I really love is the emergency room physicians coming in there with me and observing or helping me examine the child so they learn for the next time, right? So my advice is, be respectful to the ophthalmologists and, try and understand and learn things as you go along.
Excellent. I couldn't agree more. And I couldn't agree with your first statement. Thinking about my pediatric residency and even my pediatric emergency medicine fellowship, I agree. Anything that has to do with the eye and training was fairly minimal, which is why I'm, again, very excited to have you on the show to answer a lot of my questions. And my first question to you, this is something that I probably should know a lot more about, but over the years I've seen so many patients and gotten so confused. Conjunctivitis is literally one of the chief complaints that keep us in business. There's something about red, teary eye that gets the parents very scared. And my personal experience that anything to do with the eye looks worse in the morning. So the kid wakes up in the morning, kind of looks really terrible. And my question to you is, when I see a child with classic conjunctivitis, red conjunctiva, irritated, discharge, etc., to what degree do I need to worry about viral versus bacterial conjunctivitis? Is it even possible by physical exam to differentiate? And do all kids with what looks like conjunctivitis need antibiotic ointment, solution, or which one is better, etc.? What do you think about those?
Yeah, well, here's my take on it. First of all, sometimes I even have trouble distinguishing the type of conjunctivitis, but there's certainly clues that you can use to determine the type. The question is if a kid comes into the emergency room with a conjunctivitis, what's the most likely cause of that? And there's really three major causes that we think about. Bacterial conjunctivitis, viral conjunctivitis, allergic conjunctivitis, or even some chemical conjunctivitis too. So one important thing you always have to ask the parents is, was the kid playing under the sink with something? And that morphs more into a chemical injury. But sometimes parents don't necessarily give you that history that maybe the kid got into something the day before. But those three things, bacterial, viral, allergic, are the most common. And there's certain clues that you can use to distinguish, what the most likely cause is. So, bacterial conjunctivitis the eyes tend to be red or more beet red, and you have that sort of mucopurulent, sort of greenish type of material coming out. One question I always like to ask is whether there's any associated sinusitis or pharyngitis or otitis. So kids who have ear infections and sinusitis, those are the ones who also tend to have the bacterial conjunctivitis as well. So those are other two clues that it might be a bacteria. It's funny because it always came up as a question since I was a fellow, what's the most common cause of conjunctivitis? And you'd always think that, it's probably a viral conjunctivitis because viruses are rampant in our communities. But there was a study that came out, probably about 10 years ago, maybe more, where they actually sent ophthalmologists into pediatricians' offices and looked at, it was probably actually the residents. But anyway, they went in and looked at conjunctivitis to determine the cause, and they did cultures. And they found out actually the most common cause is bacterial conjunctivitis. And that was a little bit different than our thinking was. But I think probably what happens is that you have, especially in young kids, if they do have some sort of viral illness going on, they might have a little viral conjunctivitis. What do? They start rubbing their eyes. And as you know, hands are just dirty. They're sticking them in their mouth and then rubbing their eye or sticking them in their ear if they have an earache or what have you. And those hands are filthy, and then they rub the eye. And I think what happens is they probably secondarily infect themselves with a bacteria. And that's probably why in these studies, the number one cause was a bacterial conjunctivitis. So if you see someone who has a sort of mucopurulent type of discharge. They may be running a little fever. They have otitis and sinusitis. That's most likely bacterial. So viruses are a little bit different because you kind of get this sort of clearish discharge. It's more like a watery discharge. So you're not necessarily getting that mucopurulent discharge. And, viruses also can cause upper respiratory tract infections and things like that. But as an ophthalmologist, the first thing I do is I check for preauricular and submandibular nodes. Now, you can get submandibular nodes with a sinusitis too, but you get these preauricular nodes, and that's really a good clue to me that it's more of a viral illness. So they also can have a fever too, but the adenopathy is, I think, one of those things that really helps point to the viral conjunctivitis, as well as sort of that watery discharge. The concern about viral conjunctivitis is that there's something called epidemic keratoconjunctivitis. And so that's a really, really bad adenoviral conjunctivitis. And that's the one that you're thinking about. Pink eye, highly contagious. You got to keep the kids out of school a couple days. And a lot of times that starts in one eye. They rub that eye, they move to the other eye. And there's also usually a history of it. Well, their friend had conjunctivitis, or everyone at school has conjunctivitis, or someone they knew had conjunctivitis. And the problem with that adenovirus is that it then can start affecting the cornea. So you get these corneal deposits and then reduced acuity. So if you have an older kid, one thing I always, whenever the emergency room physician calls me, the first question I always ask them, well, what's the vision, right? Because if the vision is down, then you're dealing with something more serious. So if you have a conjunctivitis where the vision is decreased and you think it's a virus, you have to be concerned that it might be this adenovirus. That's epidemic keratoconjunctivitis. And then the third thing, of course, is allergies. Allergic conjunctivitis tends to have more of this sort of stringy type of discharge. They sometimes have any other allergic symptoms going on. Sometimes the older kids sometimes try to pull that little stringy material out of the eye because it's very bothersome. And then, it's associated typically with certain times a year, like right now here in Reno, all of a sudden the flowers are coming up, the trees are in bloom, that sort of thing. Sometimes you see it in the fall with the fall leaves. And these kids typically have other history of allergic things, like they may be atopic or allergic asthma, and those sorts of things. And so that's more consistent with an allergic conjunctivitis.
Very good. So, sort of along the same lines, when I am concerned about bacterial conjunctivitis, and again, that's something that, despite my experience, I don't think I've ever gotten good education about. Is there a preferred treatment? In other words, ophthalmological gentamicin versus Bactrim versus ointment versus drops? Is there something that is better than others?
Well, I don't know if there's any really good studies on it, but I can tell you what I do and my thought about it is. So, there are actually some studies that suggest if you have a kid who has otitis and sinusitis and you're putting them on an oral antibiotic, that the bacterial conjunctivitis will improve as well. But the problem is that bacterial conjunctivitis, even though we don't think of it as contagious, it actually can be contagious. And there's actually a couple good reports of contagious bacterial conjunctivitis through the CDC. And one outbreak, as I recall, was in Maine, where it hit a bunch of elementary schools and teachers got it and everything like that. Because the most common cause of the conjunctivitis is staph, strep, and H flu, right? So, and that's probably typical too. I'm not a pediatrician, but as well as sinusitis, right? So you have to cover the staph, strep, and H flu. And if you put in an eye ointment or eye drop, the chances are that's going to kill the bacteria pretty quickly. So then the question is what's the most common thing that you might want to use? And I have my own personal bias, but I'll start with, if you look around the country, I think the most common antibiotic ointments people use in the eye is either erythromycin or polytrim, polymyx and acetotracin combinations.
That's
And
what I
the
use.
problem with those medications is that in some instances, the organism that you're covering is resistant, right? Because those are bacteriostatic antibiotics rather than bactericidal antibiotics. And because we're using all these bacteriostatic antibiotics in our community, we're seeing a lot of resistance. And the outbreaks of the conjunctivitis that has been communicative are the ones that, when they went in and cultured it, were resistant to erythromycin. So like your strep pneumo, that's resistant to erythromycin. And so I prefer not to use erythromycin if I can get away with it, or recommend using polysporin for the same reason. The other thing is, if you look at how you have to dose it, because it's a bacteriostatic, the doses is every 3 hours for 5 to 7 days. Can you imagine putting an ointment in a kid every 3 hours for 7 days? No parent will be able to do that. First of all, you have to pull the kid out of school, right, to do it. And second of all, you have a screaming kid, trying to hold them down and putting an ointment in every 3 hours is really difficult. So if you just look at compliance to that, it's pretty abysmal, right? And so because they're bacteriostatic, that's what you have to do it. So I prefer using a fluoroquinolone like moxifloxacin or ofloxacin. And the reason why is because it has a little bit broader coverage of bacteria that we're interested in, staph, strep, and H. flu. And in the teenage kids, you always have to worry about chlamydia. So it'll also cover chlamydia, so you got a pretty good coverage there. And then it's also bactericidal, right? So since it's bactericidal, the dosage regimen, I believe, is 4 times a day. Although there are some studies that says if you use that as a drop 3 times a day, it works just as well. And probably part of that is you're just putting the antibiotic right on the bacteria. I mean, where, other than a wound infection, where else are you putting antibiotic right on a bacteria but in the eye, right? So I think that tends to treat the conjunctivitis fairly quickly. And I think using the bactericidal versus bacteriostatic antibiotic helps prevent resistance in our community.
Excellent. Well, that was very, very good overview. Excellent for us. I got to say, I usually use polytrim. Maybe I probably should change my practice based on that. That's really good to know. Next question, and again, another challenge, Mitch, that I often come across in the PZR, the newborn that has, red, teary eye with some discharge, where I'm possibly concerned about conjunctivitis, which in a newborn could be a big deal. Some people advocate for a full septic workup, chest x-ray for chlamydia, etc., versus lacrimal duct obstruction, which is really no big deal. Do you have any tips for us pediatric providers for differentiating between the two?
Yeah, well, neonatal conjunctivitis is one of those things you always have to keep in the back of your mind. Most of the time that occurs really within the first 5 to 7 days of life, right? So most of the time, the babies are even still in the nursery when they're diagnosed with that, especially Neisseria. I mean, that's pretty obvious. The babies come out within a day, all of a sudden they're getting this bad mucopurulent conjunctivitis. The thing is that most nurseries are now prophylaxing against that, right? So as soon as the baby's born, they put in whatever ointment they're putting in to help prevent that. So I think the number of cases that I've seen of neonatal conjunctivitis is really minimal. I mean, you think the one thing you might worry a little bit about is chlamydia, but usually that presents within the first week of life. And those babies tend to be a little sick. And those are the ones that actually need to be admitted for a septic workup, chest x-ray, maybe get them on systemic erythromycin. There's some people who recommend a lumbar puncture too. But I think the number of those cases that you end up seeing in the emergency room is pretty small, personally.
So statistically speaking, you think maybe more lacrimal duct obstruction?
Right. So lacrimal duct obstruction is one of those things that all of a sudden, within, say, the first 4 to 6 weeks, the parents are noticing, especially in the morning, that there's sort of this mucoid material. Sometimes it's sort of greenish on the eyelashes. Sometimes it's enough to cause conjunctival irritation. But if you actually look closely, the conjunctiva is not that inflamed, right? So that's one clue, is if you can open up the eye and look at the conjunctiva, usually it's pretty white and quiet. It's not really red and inflamed, unless there's really a bad secondary infection, which is pretty unusual. So, the parents complain, you have this mucoid material. Sometimes it's there all day. It tends to be worse in the morning because they're not opening up their eyes at night. So the normal pump mechanism to try and get rid of all that material isn't occurring because the babies are sleeping and they're not blinking. And when I see a baby in the office and has all that material on the eyelash, and I think conjunctivitis, the first thing I do is I put some gloves on and I press at the nasolacrimal sac and I look and see what's going on at the puncta. I ask the parent, don't wipe it away yet, because I want to see what's going on. You push there, and then the material comes out, and then you've made your diagnosis, right?
Excellent.
And so, nasolacrimal duct obstruction is really, really common. I see a couple of babies a week with it, and I'm sure some of them have gone to the emergency room too, and then end up getting to see me because the emergency room, it needs to be probed, right away or what have you. But the natural history of these things is that we think there's a tiny little membrane where the nasolacrimal duct exits into the nose near the inferior turbinate. And as the nose expands and the baby grows, that little membrane opens up and opens up more, and all of a sudden these things go away. So 90% of nasolacrimal duct obstructions will resolve by year of age and end up not needing to be probed. Sometimes if it's really gooky in terms of the mucopurulent discharge, I'll give them a little antibiotic ointment, or sometimes I combine it with an antibiotic steroid. I don't necessarily recommend the pediatricians or the emergency room docs use steroids, but I'll use it because we need to follow their pressures in their corneas. But a lot of times if there's inflammation there at the edge of the duct, it tends to open it up. And it certainly takes away some of the bacterial infection or secondary infection. And then sometimes you just sort of get more of a watery discharge rather than mucopurulent discharge. And then we wait and see what happens.
Excellent. Very good. So again, great tips for us. Again, something I see quite often, and I always try to do my best to differentiate between the two. Do I need to condemn this child for antibiotics or just warm compress? So really helpful. Thank you very much. Last question, Mitch, and again, this is something that I personally started doing when I got a little bit more experience in pediatric emergency medicine, and maybe I'm doing the wrong thing, but it's impossible for ophthalmologist and a pediatrician to have a clinical discussion without talking about corneal abrasion, which I see all the time. And every once in a while, I get a child, usually it's a toddler, that I know he has a corneal abrasion. Somebody rubbed his eyes, one eye, and now it hurts a lot, and it's red, etc. And I know, and again, my experience, this child is not going to tolerate corneal staining. And at some point in my career, I became comfortable to say, this is probably corneal abrasion. This kid is not going to tolerate the procedure. Is there any harm in skipping the corneal staining and just providing antibiotic and follow-up? Can corneal abrasion be a clinical diagnosis?
Well, you're talking to an ophthalmologist here, right? And
sure.
So my pet peeve, even with ophthalmology residents, it is your job to look at the eye, right? That's your job. You have to look at the eye no matter how. And so even in the emergency room, the problem is that even clinically, you think, oh, this kid has a corneal abrasion. You weren't there when the injury happened, right? So you don't know whether there was something more substantial, and you don't know whether the globe is ruptured or they have a corneal laceration. And those are emergencies. So the one thing you don't want to miss those. So, and I've told the emergency room physicians this too. There's no reason why you can't put in an anesthetic drop in the eye. Back in the old days, and I was taught this, that if you had a ruptured globe or a corneal injury, if you put in an anesthetic drop, there was a chance that the anesthetic could go into the eye and you could have some toxicity and things like that. But the problem is you have to take a good look. So if you have a screaming kid coming in with a corneal abrasion or any ocular thing, just put in some proparacaine or tetracaine drops. And 99% of the time, it'll take away the pain. And a lot of times it'll just open up the eye. You know, a baby might be a little different,
Sure.
but I throw in those drops, and then I'll even take my little fluoresce strip and I'll put the drop and then sort of drop that in the eye too. And so that way you're sort of staining it at the same time. And then, you know, if you're comfortable, certainly with the babies in my office, if I can't open the eye up after that, I do put in a speculum, you know, and that opens up the eye because I have to take a look. So, you know, the thing you want to make sure is that there's no corneal laceration. And that would be the worst thing, to send them home. And then a couple of days later, maybe even a week later, when they finally get in to see the ophthalmologist, you know, you find out you had a small corneal foreign body that was stuck in there that just didn't dislodge, or a small corneal laceration or something like that. And then you have to take the kid to the emergency room. So my recommendation to you would be to, there's no harm in throwing the proparacaine drops in. You know, if it's any kid over age, so 4 or 5, my experience tells me that once you do that, they'll open up their eye and you can take a look, really see what's going on.
Excellent. Thank you very much. No, that those again great tips. Mitch, thank you very, very much for coming on the show. These were really, really helpful. And I am not sure that if you familiar with the PEM rule traditions, but the guest in the show get to choose the outro of his choice. And you gave me a list of outros you would like to hear, but you also indicated that you're a musician and you play the keyboard and you have your own band. Is that right?
Right. Yeah. So there's a bunch of us old guys here in town. We formed a 80s rock band, mainly because our kids started playing music, and we had played music at one point, and some of the dads were starting to take lessons. And yeah, we have an 80s rock band. We just play for fun or charity events. So,
and do you by
play
any chance have recording of any of those songs?
Yeah, but you probably don't want to listen to them.
Well, I know you indicated one of the songs on your list was by Stevie Wonder, right?
Yeah, one of my favorites.
A great song. I've done it before on the podcast. I'm going to revamp it a little bit with a new bass guitar that I just got, actually. And in honor of you coming on the show, we're going to play Stevie Wonder.
Thanks. It's been a pleasure.
Thank you very, very much. Really helpful tips. I truly appreciate your time. Thanks a lot. And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Mitch and his extensive experience. Again, ophthalmological emergencies can often be a little challenging, to say the least. Please continue to check out PEM Rules, and if there's anything you want to hear on the show, any subspecialist you want me to host, or any rules you want me to discuss, or if you just had an interesting case and want to discuss it, let me know. I'm always happy to help. Just contact me via pemrules.com. This is my attempt to do Superstitious by Stevie Wonder. Hope you like it. Thanks very much.